Professor MSL Salgado Oration 2020, delivered by Dr. Anil Jasinghe, Director General of Health Services, Sri Lanka. Medico-Legal Society of Sri Lanka organizes two main orations every year. Dr. W.D.L. Fernando Memorial Oration, the Medico-Legal Society Oration. This year, starting from this year, the Council of the Medico-Legal Society decided to rename the Medico-Legal Society Oration as Professor MSL Salgado Oration, taking into consideration the immense contribution made by Professor MSL Salgado to the field of legal medicine in Sri Lanka and also in the region, as well as his immense contribution to the Medico-Legal Society of Sri Lanka. So, virtually this is the first Professor MSL Salgado Oration organized by the Medico-Legal Society of Sri Lanka. And also this is the first time the Medico-Legal Society goes online, taking into consideration the new normalcy prevailing in Sri Lanka as well as the rest of the world. Probably one of the few orations delivered online, and Dr. Anil Jasinghe, the Director General of Health Services of Sri Lanka, has kindly accepted our invitation to deliver this inaugural Professor MSL Salgado Oration. Managing the COVID-19 pandemic in Sri Lanka, lessons learned and way forward is the topic for today's oration, taking into consideration the immense work or the contribution by Dr. Anil Jasinghe, his contribution in managing the COVID-19 pandemic in Sri Lanka during the past few months, and also taking into consideration the timeliness of the topic given the present situation of the Sri Lanka as well as the country. And the Colombo Law Society came forward to assist the Medico-Legal Society of Sri Lanka by providing the online platform, allowing the Medico-Legal Society of Sri Lanka to deliver this oration online despite the given or the current restrictions that are in place with regard to many parts of Sri Lanka as well as in the world. So we thank Mr. Vijay Gamage, the President of the Medico-Legal Society, the President of Colombo Law Society, as well as the Council for coming forward to assist the Medico-Legal Society by providing the online platform. And also it is my duty to recognize the family members of Professor Salgado who have joined with us today in this oration. And it's time for me to invite Dr. Ajit Tennapon, the President of the Medico-Legal Society of Sri Lanka, to read the citation of Dr. Anil Jasinghe. Dr. Tennapon, over to you.
Thank you. Good evening, all the participants. Let me welcome all of you to this Professor MSL Salgado online oration 2020. And we invited Dr. Anil Jasinghe, Director General of Health Services of Sri Lanka, the main actor in the fight of COVID-19 pandemic in Sri Lanka. Dr. Anil Jasinghe received his second education in Ananda College, Colombo, and Dr. Jasinghe graduated as a medical doctor from Lvov State Medical Institute in the former Soviet Union, and holds the postgraduate qualifications MSc Community Medicine and MD Medical Administration from the Postgraduate Institute of Medicine of the University of Colombo. And also he obtained the degree of Master of Public Administration from the Postgraduate Institute of Management of the University of Sri Lanka. He joined medical administration as the medical superintendent of the provincial hospital Badulla in 1996. Then he became the deputy director of the National Hospital of Sri Lanka, in charge of the accident service at the height of the terrorism and in 2009. And then later he became the director of the Colombo South Teaching Hospital before he been appointed in 2012 as the director of the National Hospital of Sri Lanka. He was then promoted as the first deputy director general of the National Hospital of Sri Lanka. Dr. Jasinghe was instrumental in establishing the Trauma Secretariat under the Ministry of Health and became its founder head. In the field of injury and trauma, he had special liking towards the burning issue of road traffic injuries, where he has contributed nationally and internationally. And also he was trained in the field of disaster management in prestigious centers in the US and Israel. He was the president of the College of Medical Administrators of Sri Lanka in 2010. And in 2011, he was conferred with the fellowship by the College of Medical Administrators of Sri Lanka. He has done many presentations in national and international forums, and his sound academic ability is reflected on various academic papers published in local and international journals. He served as a board member of the State Pharmaceutical Corporation and National Transport Commission. And he is the chairman of the Board of Study Medical Administration in Sri Lanka and a member of the Board of Management of Postgraduate Institute of Medicine of the University of Colombo. Since December 2017, Dr. Anil Jasinghe is called in the post of the Director General of Health Services in Sri Lanka. And also he was recently honored as the Vice Chair of the 146 sessions of the Executive Board of the World Health Organization. Now I will invite Dr. Jasinghe to deliver his presentation. Before that, I would like to present a medal of the orator from the Medico-Legal Society of Sri Lanka.
President, Medico-Legal Society, Dr. Anil Jasinghe, the Secretary of the Medico-Legal Society, ladies and gentlemen, let me first thank the President and the Council of the Medico-Legal Society for inviting me for this prestigious oration. Professor MSL Salgado Oration 2020. It's an honor for me to deliver this oration today evening. And just few words about Professor MSL Salgado, who was a eminent forensic pathologist Sri Lanka produced. And I had the privilege of listening to him, and also privilege of meeting him several times, and met in his office and listened to him, and then also I met him in my office several times when he visited me. So as we all know, he was a great son of Sri Lanka, and he did yeoman service to the specialty of forensic pathology, and of course as well as to the legal fraternity. Let me start the presentation on COVID-19, the lessons learned and way forward. The current status with regard to COVID-19 is that we have actually this was updated as at 20th July 2020. The case load was 2,730. And as you know, we suffered 11 deaths, and the 2,448 were cured. And the first case was detected on 27th January 2020, and since then 25 weeks have passed. And the next, the map of Sri Lanka with the clusters and the cases. Of course, you get all the cases by MOH areas on this chart, and then the clusters means you get the quarantine centers, you get the cases that were found in relation to the index cases in the society, and also the cases that came as a result of inbound arrivals. And next, you will see how the Sri Lanka map changed over the time from the beginning of the COVID-19 epidemic up until now. Now, the red means the red areas in this map are areas where there had been cases during last 14 days. And the green means areas where there were cases beyond last 14 days. Amber or yellow means there had been no cases at all. So you could see over time there are red patches coming up, and then when the third map you can see a green patch, that means the over 14 days, and then of course you get more and more green red patches with especially with Navy cluster, because though that was confined to a Navy camp, because there were other cases connected. And then once again, the map becomes green and yellow with the control of those clusters. And then you see the last the map of Sri Lanka. Once again, you get a few red patches. That is the Salgado cluster and the surroundings of the Salgado cluster. Now, this is the case load 2,730. Out of them, 1,825 or 66% were found in Sri Lankan context, and then the 875 were Sri Lankan returnees. You know, from various countries, the government took a decision to bring them on repatriation flights. So that resulted in 875 cases. And then the foreign nationals, 30. So when it comes to Sri Lankans in country, 366 were found in the community, and 77 in community quarantine camps. And then of course our biggest cluster, 906, that's Navy. And then the next inmates means the Salgado cluster. They produced 452 cases, and the staff of the Salgado camp, there were 24 cases. So, and then when it comes to returnees, there were some were found in, majority were found in quarantine centers, and then also some were found in community. And these are the clusters in Sri Lanka, starting from Italy cluster, then the pilgrims. Pilgrims means there were pilgrims to Qatar, Indonesia, right? And then we faced Sudwella cluster, and then Keselwat, the Bandarnayakapura urban slum cluster, and then the large naval camp cluster, and then of course returnees from the other country, from overseas, the Sri Lankans, and the next is covered in this picture, that is the Kandakadu cluster. You could see all these clusters have come up and then they have been controlled. And lengthwise, these clusters are different from one to one. And then the size of the cluster also differ. If you take the naval camp cluster, that was the longest serving cluster. Now it's luckily it's no more. Of course returnees cluster is longer. That's because the repatriation flights are continuing. So that's the reason. But Navy cluster is one cluster which lasted longest in Sri Lanka. Even Kandakadu cluster, you could see the length of, if you go by length of time, it's very short and it's almost under control. So we hope that we will soon control that cluster. And next, these are the countries from where Sri Lankans were repatriated. And for example, 45% or nearly 46% of the returnees came from Kuwait. So, and you can see the other countries as well. Then the distribution of patients by age, you can very clearly see that the majority, overwhelming majority of patients were in the middle, the young and the middle age groups. That is from 21 to 30 years, 31 to 40 years, 41 to 50 years. That is the major chunk of patients in Sri Lanka. So you could see above 51 to 60 and 61 to 70 are, that's a very small number. So this is a very important slide, important observation, where in Sri Lanka, the disease was mainly confined to the young and middle age groups. As you know, world over, the more and more deaths were found to be where the virus crept into old age groups. So now here in Sri Lanka, the control measures that we adopted prevented the virus, reaching old age. So that is the success. That is why we had only 11 deaths. You just imagine if we had more and more elderly people catching this virus, the situation would have been entirely different. Then here you see 97.6% patients got through the direct contacts with diagnosed patients. So that means exactly we knew who gave the disease and who received the disease. And then the others, and only 14, the exposure was uncertain during those days. And next, now the first, the big square, you could see primary cases 1,782. The primary cases means the first cases from whatever the cluster, the first cases. So primary cases can result in secondary cases. Now in Sri Lanka, you get 1,782 primary cases, and it resulted in 1,561 cases. That means these 1,782 couldn't infect even the same number of the patients. So the less than the number of primary cases. So generally, as you have read world over, this disease amplification is very high. So it's not 1 into 3/4, but it's 1 into 10, 100, 1,000. That's the amplification kind of in this disease. So once again, this shows the severe control measures that were adopted in Sri Lanka resulted in curbing this disease at the primary case level. At the primary case level itself. So the tertiary level, you get the small square there up there. That's just 221 cases. So, but now in a rampant transmission, what you could say is you will have primary cases and the secondary cases much more than primary cases and tertiary cases much more than second. Now, our situation is vice versa, which is a very good observation and result. Now, this graph, you could see the blue, that's cumulative recovered number of patients over time. And then the red one, the cumulative number of cases. So you could see that these two lines almost trying to meet each other at the right, upper corner, right, just before. So that was the time when our caseload was reduced to over just 100. And then the mouth opens once again. That's due to Kandakadu, the cluster. But now we are once again in a manageable situation. Now, you could see as at now, the major chunk is patient recovered. That's 2041, the number, and the currently So this is the, I think, most important chart, the bar chart, where you can see the title, the days taken to detect case number 500, case number 1000, case number 1500, case number 2000, and case number 2500. The countries in comparison here are none other than Italy, South Korea, Spain, UK, Germany, France, USA, Japan, Singapore, Sri Lanka. So those are the countries. Those are the countries actually which were highlighted with regard to COVID globally. So now here you see, if you take Italy, Italy took 28 days to reach first 500, right? So that's blue, the blue in the bar, every country. Then the other country 34, 37, 38, so forth. And then Singapore took 60 days to reach its 500 case. Sri Lanka took 90 days. So that means Sri Lanka took longer time to reach 500, which is a very good situation. That is once again due to the very severe control efforts. And then the next 500, that is the 1000 cases. When we reach the 1000 cases, the next 500, during a time of 23 days, Italy, even you can't see, I think 1 or 2 days. within 1 or 2 days, they reach the 1,000 cases. And then next 1,500, there of course Sri Lanka got higher multiplication in the sense, I think this was purely due to naval cluster. Within 9 days, we got the other 500. But if you take all these, the COVID famous countries, right? All of them, all of them consume less than 9 days to reach that 500. And then next 500, that is the hitting 2,000, it took 27 days in Sri Lanka. All the other countries took just 1 to 2 days. And 2,500 cases, once again, 17 days we took, and the other days you can't even guess, maybe 1 to 2 days. So this once again shows that we only one hand we crushed the COVID-19 very quickly in a short period of time, and that led for slow acceleration of the cases. Right. That's why we had a slow acceleration compared to all the other countries. Now, how we controlled this disease in Sri Lanka is due to very many actions, decisions that were taken daily basis from the very first day. So this is a long list, very long list. So therefore, I will just confine to some of them, the initial things, because our the major reason for success of Sri Lanka was that early actions that we took. We were actually we took actions much earlier than many other countries and much faster. So for example, by 23rd January, we established National Action Committee against COVID-19 by His Excellency the President. And then 25th of January, we established screening facilities at ports of entry. And we established the first COVID PCR lab in MRI by 25th of January. And but at that time, only we and Pune had laboratories in this region. And just after 25th, maybe close upon 30th, I went to Geneva, and I had to transit through 3 airports, the Dubai, Geneva, and then on my way back some other airport, and none of them had port of entry screening in situ. So that was the situation. And then by 26th, the next day itself, we worked out a working case definition on novel coronavirus for Sri Lanka. And then 28th January, we got the first patient, that's the Chinese lady, right? We could diagnose because we had PCR facility by then. Otherwise, we wouldn't have diagnosed this case, we then would have been in trouble. And then 29th, next day itself, we restricted issuing of online visa, right? And 30th, next day itself, we established the Diatalava, the quarantine camp. And then on the same day, WHO declared novel coronavirus outbreak as a public health emergency of international concern. Then the 2nd of February, we introduced health declaration form at Bandaranaike International Airport, as you know. And then 5th of February, National Technical Committee was formed, which was headed by Director General of Health Services, which of course met from that time up to now on a regular basis. And then this case definition of COVID-19, we changed several times depending on the changes of the transmission of the pandemic. We kept on changing case definition time and again. And then by 10th of February, we identified hospitals with isolation facilities for treatment of possible COVID-19 around the country. Not in only big cities, but all over the country. We started off introducing 12 hospitals and ultimately ended up around with around 30 hospitals. Then 24th February, follow-up of Sri Lankan and other foreign nationals, and that's those who come to Sri Lanka, we followed up them at their houses for 14 days. Then by 2nd of March, disembarkation of passengers and crew members was banned in Sri Lanka. So I just referred to from 23rd January to 2nd March. So you could see almost every day a major action targeting this disease had been taken, and that's how you can see when you just turn pages. These are all actions that we have been taking. So all major actions. So then when it comes to PCR testing, because PCR testing is a major action in prevention. Now, in our prevention, in our control, the contact tracing, quarantine, testing, they are the and treatment. They are the main pillars. So, as at 20th, we have done, you can see, 142,868 tests. So actually, by now we have reached 150,000. This was as at 20th. Now you could see here 22 labs. 22 labs. You could see the government labs, and when we started these labs, because PCR testing is a very complex procedure, and it's not easy to start a PCR lab. So, but we were able to start all these labs in Sri Lanka, one after the other. And also the private sector also joined us. 4 private hospitals already are in the system. And when it comes to a positivity rate of PCR, now initially it was about 3%. That is, out of 100, 3 become positive. Now, as at today, the positivity rate is about 1.8%. So that means the virus is sort of, coming down. You see less and less virus among the people. So that means we do more PCR tests, but we get less harvest, less and less harvest. Now this is the private sector. You could see 15,381 tests were done by the private sector. And then the community samples, here you get 32,187. And the quarantine centers, 25,195. And then this is the average number of PCR tests. This is bar chart, the lower part of the slide. You see the bar chart. This is the average number of PCR tests per week. You could see from week 8, it's just point something, and then it is going up, and there are, you know, ups and downs here and there. But you could see now it ends up in 2,197. So if you take last 2 weeks, every day we have done over 2,000 tests, PCR tests. So you could see that there is incremental increase of average PCR tests per week, means per day. So all these tests are done by those labs that I mentioned a little while ago. Now, when you take the active cases with total bed strength, now you see the red color here, that line is the number of active cases. And the yellow, that's the number of treatment beds. You could see these two lines never met. So that means we kept our surge capacity on the check. So therefore, we never had a problem of beds during this COVID period. Of course, in fact, now the situation is much better with less number of patients. Now, next, these are the COVID treatment centers. Now, you know, this IDH is the historical infectious disease hospital in Sri Lanka, but all the other 12 hospitals, they are either general hospitals, you know, the treating patients in general manner, or some of them were non-existent. We built for this purpose. Now, and also 2 hospitals we totally converted into COVID treatment. That is Mullaria and Homagam. We took over these 2 hospitals, and these 2 hospitals were totally committed for COVID treatment. And the Valikanda, that was the second hospital after IDH. As you remember, there were cases coming in these quarantine centers located in Trincomalee and Coronado district. And we had 2 options, either to bring all these patients to Colombo or set up a hospital there. So actually, we went for the second option. We converted Valikanda base hospital into a COVID treatment center with the support of Army, and that was a fantastic effort. And then Iranavilla was the Voice of America station, and it was just empty building, and with the support of Army, we converted this to a COVID treatment hospital. So, and the other one was Kandakadu drug treatment rehabilitation center itself. We converted into a treatment facility, because these inmates, being drug addicts, you know, putting them into other hospitals would create problems, and even for them it will be unfamiliar terrain when it comes to other hospitals. They were there for quite some time, 3 months or 6 months, so they were used to that setting. So the best decision would have been that. And then towards a new normalcy, so we developed advocacy brief and the timeline, instruction notes, the assurance forms, and so a social marketing campaign is to begun in no time. Maybe next week we will start this social marketing campaign. And this is we call it DREAM. D for distancing, RE for respiratory etiquette, A for aseptic techniques, M for mask. So these are the advocacy briefs and other documents with regard to this, and this is the timeline. And the most important, the lessons learned during this COVID battle. One lesson is importance of successful contact tracing. Now, in epidemiology, when it comes to infectious diseases, this contact tracing is a fundamental, but it is of paramount importance when it comes to a disease like COVID. So we were very successful in contact tracing, and this, of course, we have the expertise in epidemiology unit and within epidemiologists and our medical office of health. But then there we come to the second lessons learned: the collaboration between primary healthcare system with national intelligence services on contact tracing, because they are the SIS, the technology came into practice with us. So they use various technologies. Though we know the theory and we know the practice, but in a situation like COVID, in a pandemic, without the support of intelligence services, it would have been somewhat difficult. So therefore, our service was, the contact tracing was very efficient due to this collaboration. And then effective community participation on contact tracing. The public used to sort of, they used to trace sometimes. They point where the possible contacts are there. So that community participation was very important. And then timely introduction of institutional quarantine and home quarantine. Now, the countries, various countries use these modalities in various manners. For example, Vietnam, they only had home quarantine. They didn't use institutional quarantine. Now, we used a blend of institutional and home quarantine. We started off from home quarantine, and then we moved to more or less to institutional quarantine at the major mode. But then later on, once again, we moved to home quarantine. So that depends on the facilities available in the houses and how many individuals in a family, and sometimes there are behavioral situations. So all these count. Then active involvement of security forces in quarantine process. Once again, as you know, we set up big quarantine centers. Some of them were army units, and some of them were taken over by the using powers of the quarantine and disease prevention ordinance. But then it was the army which changed, which did the civil work to convert these buildings. It's not easy. We in health would not be able to do those things on our own. So, but expertise, how you set up quarantine process, how you set up these facilities, of course, were all done under our guidance. Then implementation of strict infection control measures within the quarantine centers. So, as you know, now that we confine many patients, many individuals into quarantine camps, the disease didn't, move out of this quarantine center. And that, of course, from within quarantine centers, we got cases. Now, all these the patients who were positive from repatriation flights were majority found in the quarantine camps. But these camps didn't infect the outside world. That is because the infection control measures that were implemented in these camps. Then the lessons learned. Targeted PCR testing. Now, we never had social transmission of COVID-19 in this country. So, that is actually, it's a pretty basic explanation, right? So, therefore, we never wanted to do PCR in, many thousands, right? So, we actually, our strategy was targeted PCR testing on targeted population groups. So, as I told earlier, our positivity rate was 3% initially, and it actually came down to 1.8% as at now. So, that's a very good situation. And then the next lesson learned was timely recruitment of healthcare institutions into COVID treatment process. So, as I explained earlier, we have 13 such institutions. Unless we recruited them, groomed them, had there been explosive nature of this disease, there would have been shortage of beds. So, we never allowed that. We always had a check on surge capacity as far as treatment capacities are concerned. Then, of course, uniformity of treatment governed by the guidelines. We had a technical team. They met every morning at a Zoom meeting, and they met physically. And whatever the technical issue comes, they troubleshoot. I just pass them, get me a solution for this. They brainstorm and come back with a solution. That is how we rejected hydroxychloroquine as a prophylactic measure. Many countries did that, but then ultimately it was revealed that is of no use. And then Avigan, the Japanese Avigan, even Japan didn't recognize, but then it was in the market, and then market forces come into play. So, but then once again we rejected. So we had a strong the technical arm, and then the political commitment and technical integrity. If not for the political commitment that was shown in Sri Lanka during COVID, things would have been drastically different. Because of the top-down approach and the timely intervention especially by His Excellency and the government, paved the way for us to work efficiently and control efficiently. But then the political commitment per se is not sufficient. You need to have technical integrity. We had that technical integrity. sometimes, we may have to argue with the political, figures, right? Because you would come to the best solution. So for that, you have to have that technical integrity. On the other hand, the political authority respected the technical integrity. So I think this coexistence of both political commitment and technical integrity once again gave good results. And then next lesson learned was rational handling of social media and mainstream media. Probably the media may not know, but we handle them. Initially, the social media started, working irrationally. But I had one thing that was every day we must provide the lead story. If you provide lead story every day, that will trickle down to all this media. If you don't provide the lead story, others will come out with various unwanted lead stories. So that was the trick. I just revealed now, but that was the trick. And then the mainstream, of course, mainstream media, they were helpful, and we had we gathered with the mainstream media, especially their organization, electronic media organization. So so therefore, ultimately, we all became one team. So we could manage to that extent. And then next lessons learned is regular technical reviews. We had regular technical reviews through which we sometimes change our decisions, we improve our decisions, and all of us know the ground situation then and there. So way forward, economic activity versus COVID. As we all know, the COVID killed economy in the world as well as in Sri Lanka. So therefore, we have to get out of this economic downfall. Therefore, we have to learn how to develop economically in COVID context. So that is one thing about way forward. And then new normals. Now, how are we going to live, during COVID, and then, just after COVID, right? Because we know that until such time that there is a vaccine, even then, even if you find a vaccine, there are questions whether we can immunize 70% of population. Now, when it comes to influenza, we don't have
Ladies and gentlemen, there is power failure at the presentation center. Please bear with us as we get back online. Thank you. Please stay tuned. We will start shortly. Thank you.
uh, it was a power failure, sadly. We are sorry about that, for the inconvenience that we underwent, which was beyond our control. I was actually on the last slide, at the last two bullets, really. So this was about way forward, the last two bullets, the surveillance system. Now that right now you could see that we have very few cases other than the cases reported from those who come from overseas, the Sri Lankans. Very few cases. So therefore, notwithstanding the low caseload, we have to have a good surveillance system. So in this surveillance system, one important thing is to continue with community PCR testing. So therefore, we are planning we will have this product in a few days. We will have a system where every divisional secretariat area will have some number of PCR testing done continuously, notwithstanding the number of cases in the country. That is to assure that there are no cases, make sure that there are no cases in Sri Lanka, because this is more than now, this will be important in future. Once we open this country to the world, the virus can come in. So therefore, we have to have these checks and balances. So therefore, we are devising this surveillance system. Of course, already we have a strong system, and we will add certain inputs into this system. And then, of course, sustenance of readiness. Now, we had SARS, we had MERS. Now we have COVID. Now, during SARS and MERS, at that time we did some work, but we didn't look forward. So, but this time I can say seriously that we are looking forward to the future. So therefore, we have already started investing, of course, with the blessings of our development partners and some soft loans, that in the future, if such pandemic or such disease comes in, we will have the set of isolation units in the country, all over the country. So already we have planned. And then we will have a fully fledged laboratory in the Medical Research Institute. And then we will have fully fledged lab and isolation facilities, novel facilities in IDH. Now this COVID, we battled with, under trying conditions with whatever the tools available, the infrastructure available with us. So our thinking is that we should not repeat the same mistakes. So therefore, we are looking forward to improve these systems very soon, within next 3 years. So our target is next 3 years. So that is what we call sustenance of readiness. So therefore, I wind up my oration, and once again I thank the audience, those who logged into this oration and listening to my oration for about 1 hour. And once again, I thank the Medico-Legal Society for inviting for this very valuable oration. Thank you. Good evening.
Ladies and gentlemen, may I take this opportunity to thank Dr. Anil Jasinghe for delivering the inaugural Professor MSL Salgado oration on the topic Managing COVID-19 Pandemic in Sri Lanka, Lessons Learned and Way Forward. And also I would take this opportunity to thank President and the Council of the Colombo Law Society for providing us with the online platform to deliver this lecture, to deliver this oration online. And also I would like to thank all of you who joined from various parts of the world, and say, although there are many participants from various parts of the world, going by the Sri Lankan time, let me say good night. Thank you.